consider for potential metabolically interfering effect of drugs. As I mentioned, for metformin, the dehydration and lactic acidosis in those patients, and how we can carefully monitor, and sometimes we can consider temporarily discontinue. The sodium glucose co-transporter inhibitor, risk of dehydration, and avoid initiating therapy if there is already the respiratory illness is going, so no initiation. And renal infection, renal function, of course, should be carefully monitored in those patients. And I think related to the renal outcomes, soon we will have one extensive review paper published on the renal outcome of the antidiabetic medication. Stay tuned, inshallah. Glucagon-like peptide-1 receptor agonist, again, dehydration risk, and you have to make sure the fluid intake or maybe the dietary or the regular pattern of meals in a given case. DPP-4 inhibitor is generally well tolerated and should be continued. Insulin should not be stopped. Regular self-monitoring for blood glucose should be there every 2 to 4 hours. Carefully adjust regular therapy if appropriate to reach therapeutic goals. And here, some of the suggested action for those in clinical setting and hospital setting can get benefit of this one. What actually it has been suggested by in UK, the Sister Diabetes Center, for the changes can be suggested to take place in admitted patient according to the stage, whether early in admission, whether severe illness. All patients should be considered for this action, or the ICU patient. You can see here in early admission, if SGLT2, just to stop and consider some adjustment. Here, the adjustment for the regimen of insulin also should take place. So the last part, I see this maybe approaching the end of my talk. The last section of my talk is about pharmacist support. What actually, as a pharmacist, when we tend to focus to utilize all this information to deal with the patient, what we can do. So we have one, save and optimize medication supply. Of course, the save and optimize medication supply would be one. The telepharmacy, the counseling and monitoring, the integration emerging evidence in the clinical practice, and the clinical pharmacy support services. Okay. What do we mean by even each one? So first, save and optimize medication supply. Of course, when we apply certain restriction on people access to a healthcare setting, and we want to avoid and to help in the social and the physical distancing, we tend to think about how we can effectively deliver adequate and safe supply of medication, and make best use of maybe drive-through pharmacies. I think here in Malaysia, this has been applied in the university hospital. The home delivery services from community pharmacy. I'm not sure, maybe in Indonesia, and this one is well established. But in my country, I'm maybe originally from Egypt. In my country, home delivery services from the pharmacist to patient homes is well established. So this one of the issue, how we can maybe make it easier and effective for a patient to receive their medication remotely without need to come. But also, we have to pay attention that we have to make sure this safe and there is no oversupply and can be kept by patient, because we tend to know that the unused medication and the improper disposal, storage of medication can affect actually the quality of the medicine and the clinical outcome. So take more medication, he doesn't store properly, he used no effect, he came for experiencing the disease complication by indirect way. So this we can, with further maybe discussion with patient, we can elaborate more on this. The second point, the telepharmacy. I think all of us may be heard by somehow about telemedicine, telehealth, telepharmacy. Actually, according to the American Society of Health System Pharmacists, telepharmacy is a well-established term. and refer to remote provision of pharmacy services by a qualified pharmacy personnel. And the gist from the telepharmacy that you have to communicate and show your empathy, the care and skills, all of this remotely without direct or face-to-face interaction. And I think there is mainly digital health intervention and remote added services in diabetes care, focusing on how remotely we can first promote diabetes self-management and monitoring. And I think now many companies have the remote monitoring connected to the pharmacy or connected to the medical doctor, so they can follow up with the patient without the patient need to come to the clinic or they come to the pharmacy. And how by this they can more ensure effective patient monitoring to be there. The pre-final point, integration of emerging evidence. As a healthcare professional, as a pharmacist, one of the common challenges for us during the COVID-19 pandemic is how to deal with this dozen of information infused every day by various platforms. If you may be on ResearchGate, you can see every day maybe hundreds or thousands of papers related to COVID-19, and this come to the terminology infodemic. Infodemic relate to maybe the magnitude, the huge amount of information here and there. So sometimes we hear something is very effective, and sometimes and later in the clinical trial proved to be ineffective. And the hydroxychloroquine is one of the common examples. I think as a pharmacist, we have to practice the critical appraisal skills, how to assess, how to follow, how to maybe very prompt integrate this updated information to the patient care. This actually is very, very important, and this actually brings us to write the commentary I will show you later. I think the last point, the clinical pharmacy support services. I think based on what we have discussed in terms of medication, the adjustment, the education that could be maybe reassured with patient. I think for this one we have to be maybe more proactive as a pharmacist, because this one will contribute helping the patient make the best use of the medication, helping the patient to have the best quality of the medication outcome is very important. And actually this one will be related straightforward to the medication adherence level. So this correlates with the outcome later. And of course, better glycemic control. As we mentioned in the very beginning, being diabetic patient with suboptimal control, with suboptimal diabetes control, bring you at a very high risk for COVID-19 pandemic. And this how maybe the clinical pharmacy, even in community pharmacy and hospital pharmacy can contribute further. I think in conclusion, just to be on time, there is several considerations for us as a pharmacist to consider while dealing with diabetes in the pandemic time. If we want to make a summary, we have to think how we can maybe the measures for safe and optimized medication supply, starting the telepharmacy counseling and make use of the technology for the remote monitoring, and of course the provision of clinical pharmacotherapy services based on our maybe understanding for the use of medication and the changes that can be performed as adjustment clinically for each and every medication. For those who are interested for further reading, this may be our article published earlier this year. Actually, many of the content of this just maybe from the written article, and other reference also I put here. This published in Journal Research and Social Administrative Pharmacy. We highlighted here all the points that we consider important for pharmacists to pay attention to while dealing with diabetic patient during the pandemic time.